So good morning. Thank you all for coming. We're really happy to have you here to help us work through the revisions, the proposed revisions of this policy. We have a lot of people here from the division. I wanted to just take a minute to introduce them. Jackie Arslan, the division's chief of staff, is here. Wendy Anderson, the program director for the pharmacy board, and she also oversees the medical board. Sam Delp is here from the nursing board. Karen Phelan, who's a new program director with us, it's her second day. She is here. She is here for the veterinary board and the podiatry board. Abby Gaskins is here for the podiatry board and the veterinary board. Darcy Magnuson is here from the mental health boards. And I'm Karen McGovern. I'm the deputy director of programs and legal affairs. I'm going to turn it over to Ronnie Hines to give some welcoming comments.
Good morning. Thank you all for coming. As you all know, Governor Hickenlooper prioritized the opioid epidemic, which has resulted in the consortium and a lot of efforts, including this one. Okay. As part of the initiative, just as a little bit of background, the medical, dental, nursing, and pharmacy boards began developing policies in the summer of 2013, given the overlap in regulation. That fall, the division hosted the Quad Regulator Conference to consider the proposed policies, resulting in an agreement to produce a joint policy, the first of its kind in the U.S. And following multiple stakeholder meetings, all four boards did adopt that policy in the summer of 2014, and it was subsequently adopted by the podiatry and optometry boards and endorsed by the veterinary board. At that time, the boards made a commitment that the policy would be a living document, a policy to be updated with changes in research, policy, and best practice. And toward that end, the division and the prescribing and dispensing boards embarked on this recent 18-month stakeholder engagement process. We've held 5 stakeholder events traveling from Pueblo to Greeley, opening meetings via webinar to gather information and feedback from multiple perspectives before we even took to revising the policy. So the draft revised policy that you have now is intended to educate a broad range of prescribers and dispensers by providing resources and tools to ensure consistent evidence-based guidance for all Colorado prescribers and dispensers. The policy emphasizes the exercise of independent medical judgment in the treatment for the individual patient while providing recommendations for addressing the public health crisis. As a reflection of this ongoing commitment to ensure all perspectives are considered as we craft this updated comprehensive policy, we're here today to discuss the proposed revisions. This is the second stakeholder meeting scheduled to review the revisions before the policy goes before the boards. Though through these meetings and written stakeholder feedback, the prescribing boards want to ensure the needs of Coloradans and the potential impact of the proposed revisions on the Colorado communities are fully considered prior to the finalization and adoption. And with that, I will turn it back to Karen.
So I wanted to just give a history of sort of the revision of this draft. In revising it, we consulted with experts in the fields of addiction medicine, pain management. We spoke with the constituents, as Director Hines referred. We reviewed current policy guidelines. We looked at new research, and we leaned on our partners. We have a very strong partnership with the Colorado Consortium for Prescription Drug Abuse. And we worked with the Department of Workers' Compensation and also the Department of Healthcare Policy and Finance. We had members of COPIC that came to our expert meetings, and we worked very diligently to get all perspectives before we looked at these proposed revisions. After we gathered all the information, the boards collaborated to revise the policy. The effort was to harmonize our policy with current policy and research and to prescribe the dispensers with current evidence-based guidelines. You will notice that the new policy includes multiple footnote references. Our last policy was a little bit light on the why, and we heard that from many stakeholders. So this time we tried to include that We obviously didn't want to have a 70-page document, but we tried to include the footnotes so that you can see the research that supports the recommendations. In a nutshell, the revised recommendations address, whoa, sorry. There we go. I'm not sure what I got next to, but we won't do that again. The revised language can be kind of put into several buckets. The first bucket we looked at was alternatives to opioids. In our last policy, we didn't address that at all. And through the work with the consortium, and particularly with the American Academy of Emergency Physicians and the Colorado chapter, we've learned that in every instance that you can avoid initiating opioid therapy, you're taking one step towards preventing the opioid epidemic. This section allows physicians to be creative. We're referencing the American or the Colorado Academy of Emergency Physicians ALTO policy, or alternative to opioids. It is a brilliant piece of work where it talks about all the different medications and other treatments for pain that can be used rather than opioids. And in fact, it will compare, say, a drug like lidocaine to its effects on the body as an opioid would affect it. The other thing that we looked at was reducing the days of treatment for acute pain. In our last policy, we didn't talk about that. The research talks about the likelihood of being addicted to opioids and the drastic increase that occurs after 10 days, only 10 days of treatment with opioids. And this we look to harmonize with the Centers for Disease Control policy. The other issue where we missed the boat the first time was the importance of assessing functionality. Functionality is the best method, according to many researchers, to assessing the effectiveness of treatment. In our policy, we stress that the functionality should be assessed early, it should be assessed often, and it should be tied to the goals for the treatment. Also, I think what we learned through the workers' compensation work was that when a patient understands the improvement of functionality as a goal, it is easier to decrease opioids and ultimately discontinue opioids. The other thing that we tried to really stress in this policy was patient education and partnering with the patient for shared decision making. We found through research that when patients are advised of the risks of opioids, oftentimes they'll forego them. They'll say, I don't want them, let's try something else. I think what happens in practice is that they don't recognize the real risks involved. And I think there's a lot of the not me syndrome. Yes, a lot of people get addicted, but I won't. And in having that very real and personal conversation with their physician, they can make an informed choice. The other thing that we included is an early exit strategy. Research has shown that when patients understand that opioid treatment is not a forever, it's not something that they're going to do for the rest of their life, it is a lot easier to discontinue or wean them from opioids. Throughout the policy, and probably one of the most critical factors in addressing the opioid crisis and in preventing death, is the frequent rebalancing of the risk-benefit ratio. Many practitioners are good at doing that at the beginning of treatment. This is something that needs to be done very frequently during treatment. And when there comes a point that the risks outweigh the benefits, there needs to be a serious consideration given to either avoiding, discontinuing, or reducing opioids. Collaborating with mental and behavioral health. That was something that wasn't a big factor in our previous policy. It's something through our research has shown that conducting an early risk assessment and bringing mental or behavioral health in early will help with potential development of opioid use disorder, or really even just the early diagnosis of opioid use disorder. And then when signs or symptoms, or when you feel like that is becoming a possibility for your patient, bringing mental health in at that point is particularly helpful. We've also heard that behavioral health also has a lot of alternative to opioid, but coping mechanisms that are helpful for patients who suffer from chronic pain. The bright lines for risk mitigation strategies, and I'm going to address that on the next slide, but those are the recommendations regarding duration, dose, and formulation. And then we also included a section about concurrent naloxone prescriptions as a risk mitigation strategy. Some practitioners will write a concurrent naloxone prescription for every time they initiate opioid treatment. Others wait until they will hit maybe one of the bright lines, like if they start giving transdermal or long-acting, or if they exceed 50 morphine equivalents a day. It's something that has been shown to save lives. The consortium has done excellent work on this, and we have a link to that in the appendix, but something that you all should check out, just the great strides they've made with the naloxone program. I'm afraid to move now. There we go. So the bright lines are typically the most controversial. We have reduced the morphine milligram equivalent per day to 50. This harmonizes with the CDC. There are studies that show that once you get above 50 morphine equivalents a day, the likelihood of overdose increases 4 times. Long-acting and transdermal formulations, the CDC says to avoid them altogether. We say this is a bright line. When you're exercising your independent medical judgment, if you believe the patient needs long-acting or transdermal, you need to initiate risk mitigation strategies, treatment monitoring, pill counts, urine drug screens, naloxone prescriptions, educating the family, making sure the family knows how to use naloxone. And then duration, and that's really one of the bigger changes. Again, we addressed the acute, non-traumatic, non-surgical pain, recommending that 3 to 7 days would be adequate. And reassessing a patient at a month after being on opioids. The studies are pretty solid that if a patient is not having pain relief, if they're not experiencing relief of their pain after 1 month of opioid treatment, the likelihood that they'll be experiencing pain relief at 6 months is very low. And then 90 days for chronic pain. If you have someone who's on opioids for 90 days, then it's time for risk mitigation. These bright lines are also the time for the practitioner to stop, reassess, and rebalance the risk benefit. And that's what we stress throughout the policy, is that at every, not maybe at every visit, but frequently, and particularly when you hit these bright lines, you need to make sure that this is the right treatment for the patient. And if not, go into your box of tools and see what else you can do. We do want to stress for people that it is important for patients with chronic pain to be treated. And this policy is not in any way saying that that is not our goal. It absolutely is our goal. But the policy is a way to provide recommendations to try to address the opioid epidemic while ensuring that patients are being treated for pain. And then lastly, this is a policy, and I say this every time. It is not a rule. It does not have the force of law. It is guidelines and recommendations for practitioners. We want to educate a broad range of practitioners, understanding that there are specialists in pain management that have a different knowledge base and have more expertise in this area. But we also want to address the practitioner who is out in a rural county and does not have access to a specialist, but needs to address the pain needs of the patient. So with that, I'm going to turn it over to you. And we want to hear your comments. We want to hear your suggestions, your feedbacks. If you have comments on any of the particular areas that we've changed, we'd love to hear that. If you have suggestions to improve language to make the policy more understandable, that is something that we're very eager to hear. Suggestions on involving mental health. We're always soliciting that feedback. How else can we bring mental health into this to ensure the best care for the patient? Darcy and Abby are going to walk around with the microphones. If you just raise your hand, they will bring it to you so that you can speak.
Thank you very much. I'm Steve Wright, here speaking on behalf of myself and the Colorado Pain Society. I also endorse the comments that are going to be coming up from Dr. Sasha and Dr. Bainbridge from the Colorado Pain Society. Trajectory of a crisis response in unanticipated situation goes through actually several stages. First is denial, and I think we're far through that, thank goodness. Second is the assignment of responsibility, often followed by strong actions directed towards those perceived to be responsible for the problem. Often too, however, in that early phase, responses do not have evidence to support the interventions. Third then is what I would call authentic leadership, and that's where DORA comes in. And by that I mean that there develops a measured response based on actual evidence about where the problems are, prioritizing the problems, and the use of evidence that balances efficacy and potential harms. I certainly congratulate the board on significant advances in the current draft. I'm not going to enumerate those. That would take a long time, but you're to be congratulated. I want to address the matter of specific thresholds in the policy. I'm aware this is not intended as a ceiling. However, it is translated as such by medical providers who fear regulatory action against them, payers who have established at times absolute limits on dispensing, and medical legal domain where thresholds have been argued as standards of care. Those are unintended consequences, but they're actually happening. Just as we expect of opioid studies that the risks as well as benefits are described, we should expect that of the interventions that occur in policies. I and the Colorado Pain Society feel that the elements that rise to the level of policy, guideline, and legislation should have supportive evidence. With respect to thresholds, while there is evidence of increased risk with dosing increases, there is actually no evidence that designated threshold interventions reduce addiction, overdose, and overdose deaths. And I can elaborate on that if you're interested. Nor is there evidence with respect to harms that might come as a result of threshold interventions in a comprehensive manner. Today, patients are having their opioids reduced and or eliminated because of the thresholds, and this can and has actually harmed patients. Inadequately treated pain increases suicidality and may double the rate of suicide. That is, just like the opioid-associated death, is death. Deserves our care, deserves our attention. The Federation of State Medical Boards recently revised their policy spring this year. They actually took into consideration the CDC guidelines and did not specify morphine equivalent thresholds. Indeed, that position is evidence-based, and their entire document is a guideline most consistent with the best evidence available. And of course, in there is least dose necessary, which is certainly appropriate. I and the Colorado Pain Society recommends that DORA endorse the federal guidelines rather than the policy under current consideration. Thank you.
Thank you.
Good morning. I'm Terry Boucher, and I'm here representing the Colorado Medical Society Prescription and Drug Abuse Committee. And I'd like to start off by thanking the DORA administration and staff for the work that they've done on these guidelines. It's been a long process. We appreciate all the input that you provided to professionals and other stakeholders, and for working with us very closely. Upon review by the Prescription Drug Committee of the red line, we found that there's one very glaring omission that has been made. And that omission is based on the fact that the bright lines, most of them came from the CDC guidelines. However, if you really read the CDC guidelines, the very first sentence states, this guideline provides recommendations for primary care clinicians who are prescribing opioids. As you go on through the document, it repeats this. And until you get to the target audience of the CDC guideline, there they even define what a primary care clinician is. This guideline is intended for primary care clinicians e.g. family physicians and internists who are treating patients with chronic pain. It goes on to also define that nurse practitioners and physician assistants are also considered to be primary care clinicians. The confusion is, for our specialists now, you've tried to extrapolate a document that was intended for a very target audience, that is primary care physicians, nurse practitioners, and PAs, and make it apply to every specialty. And it doesn't work very well. There's great confusion. And we know, even since we've worked on the very first quad boards, where we had 120 MMEs, that yes, it's a policy, we know that, but PBMs and pharmacy corporations adopt these as etched in stone. And we're wanting either, when you put up the bright line like this to say, just as the CDC said, these are intended for primary care clinicians, or some way state that someone who's not a primary care clinician should use their best clinical decision making to reach MME judgment.
Thank you, Terry.
I really don't need a microphone.
For the webinar.
Oh, for our webinar.
All right. All right. My name is Sam Myrick, and I see some problems with what I'm looking at up here. That's why I wore shorts today, show people I have had 3.5 knee replacements. I've lost my patella from an auto accident. I don't see a listing of what kind of pain people are in. I've been disabled and on disability for over 25 years. I volunteer at North High School, Skinner Middle School. I've run chess clubs. I helped run a chess tournament for 120 kids on Saturday. So you guys are not addressing the different types of pain, you know, everything from neurological to bone pain, until somebody has had bone pain, for like when I lost my patella from a dump truck accident. It is an entirely different pain than someone who has a muscle. You cannot almost treat a bone pain without an opiate or something strong enough to get into it. As you guys can see, I'm a horrible addict. I'm not very clear-minded, or you know, you guys should be afraid of me. But you shouldn't. I've been on opiates for almost 25 years. And I have I'm halfway to 122, as I tell the kids in school. So I'm looking at no other choice in my life but opiates for the rest of my life. I've gone through every modality that there is out there, and I don't want to have them come back to me one day and say, okay, well, this has worked for you for 25 years, but because someone else is abusing it, we're going to yank it from you and make you go back to Tylenol again or aspirin. And I used so much of that for so long, it affected my stomach, my kidneys, my liver, and of course this will probably affect something in my body too. But I take, and I'd like to know what 50 milligrams of morphine equivalent is for Oxycontin, which I take Oxycontin every day. So I don't want to see people that really need this have it blanket pulled from underneath them. And what are we going to do for people like 90 days for chronic pain? Let's see, I'm on about 9,000 days of chronic pain. So what are you going to do for me? If you're going to pull this one thing that has worked for me, I go to a pain doctor, every 2 or 3 months. They do the urine analysis. They make sure that, you know, I'm taking them. I've turned prescriptions back in, because the majority of people that I've known that are on any sort of opiates, they hate them. I hate them. If they didn't make me feel normal, instead of like people take them to get high, and then they do have problems with that. So what is the solution for this? Because every person is different. This young lady right here, she's going to have a lot lower dose that she would take to help her pain versus my, well, remember folks, this is fat. I mean, this is famine insurance, not fat. So when you get old, you need some. So I'm going to need more painkiller probably than she does. So you need to make sure this fits every single person, not just a blanket to try to cover our collective asses, excuse my French.
Thank you so much for coming down and sharing that. Okay, we're going to switch and do someone from the webinar, and then we'll come back to the audience.
Hi, my name is Lisa Pearson. I have a pain management clinic in Canyon City, Colorado, and I have a couple of things that I would just like to talk about. I think they're the bright line with the 50 morphine equivalents a day. I think that's a pretty arbitrary number as well. You know, if you look at some of the research out there, there's 20 morphine equivalents a day and the overdose rate starts to increase. And we really can't regulate down to that or put guidelines down to that. I mean, that's going to hit everybody with any level of acute pain. One of the other concerns that I had are regarding discussions within it about caution using methadone and fentanyl for prescribing. And there are real concerns with insurers who will not let you prescribe a medication until you've tried their three preferreds. The three preferreds are methadone, fentanyl, and morphine 90% of the time, because they're the cheap drugs. And so if we cannot get another medication without trying those first, this guideline is difficult to follow. Another concern is that as we change dosing with patients who are outside of guidelines or patients who have aberrant urine drug tests, if we become stricter with what we're doing with prescribing in general, we discontinue more patients from opioid prescribing, or we decrease patients who are very upset initially with decreases in their prescribing, and they complain to the boards regarding that. And I would like to see a separate committee created within the various boards where patients who have had opioids that are complaining to the boards about their treatment, first it goes through a committee of pain management people who recognize what the guidelines are that are out there, what is normal prescribing, what's outside of normal, so that they can advise the investigative boards as to standard care of patients. And that's just my quick version of the things that I had some concerns with.
Thank you so much. Okay, who else? Don't be shy.
Thank you. My name is Marjorie Zimdar-Zorthman. I am a member of the consortium, but I speak today for myself and for my husband. I attend the PDMP work group and have learned a lot in that, attending that work group for the last 2.5 years. And I would like to echo some of the other speakers that I appreciate Dora holding these meetings this past year and taking comments. Your current draft adds some clarity regarding pediatric patients per footnote 8, that the guidelines are specific to adults 18 years of age and older. Also, that the guidelines are not intended to address the treatment of pain for active cancer, palliative, or end-of-life care. However, I think these important statements should be in the body of the preamble and not just in a footnote. It's also good to see an emphasis on including family members in patient education. Opioid use is a shared responsibility between doctors and a patient and the patient's family. On my husband's 20-plus year journey in chronic pain, I certainly have been involved in his care, I believe, from the second opioid prescription that he got for Demerol, and I had to go back to the pharmacy twice and insist that they fix the instructions they put on it, because when I had picked it up for him, he said, well, if I take it this way, I'll be dead. So they had made an error. I am much less impressed in this draft with the statements regarding reviewing current literature and being evidence-based. The article from 2010 that is referenced in footnote 3 as a study about addiction mentions only dependence. The abstract of the article discusses risk factors for opioid dependence. Nowhere in the abstract is the word addiction used. In the conclusion it states, in the conclusion of this abstract it states, these preliminary findings should be useful in future research efforts. Interpreting this article as saying that nearly 1 in 4 patients using prescription opioids for chronic non-cancer pain in primary care settings struggle with addiction is not a correct representation of this article. In addition, all the authors are connected to one healthcare company in 31 counties in Pennsylvania, which sells insurance and provides medical services. And since the data in this article is not specifically about addiction statistics and is from 2009 and not published in any American addiction publication that I know of, you should present other references for your addiction footnote. 2 years ago when I made comments before the CDC policy went out, I believe the statistic from the CDC that I ran across was their estimate that between 8 to 12% of people on long-term opioid therapy may have an addiction problem, and I'm sorry I did not have time to verify that last night and find the exact reference. Okay, regarding opioid doses over 50 MME, there is not an adequate number of pain specialists in this state for primary care doctors to refer patients to or even to have a consultation with. It would be helpful, I believe, if the boards would find out why CU School of Medicine is not training more doctors in pain management so that there is not such a shortage. Also, the board should consider encouraging the legislature in finding funds to have pain specialists available in rural counties. The information of 50 MME will be picked up by insurance companies, as previous speakers have said, as law and will be, quote, enforced on patients as the 90 MME already has. More disruption for patients and doctors will occur and more patients will be undertreated for pain. Is our state government ready for the avalanche of disability applications from people who are no longer able to get through a complete workday and the drive home without having to stop and rest because of being in pain? And yes, I know people in that situation. And are we ready for the suicides related to taper downs which have nothing to do with caring for the patient? Maintaining employment should be listed as a functional goal. For the patient that demonstrates suicidality, it may be because of undertreatment of intractable, unrelenting pain. For our household, just an update on that, I had spoken a year ago at the November 2016 meeting. My husband has been accepted into a palliative care program just last month. What this will all mean for his care, we're not quite sure at this time. We've only had one initial meeting and we'll have the other one soon. Without a PDMP data field for palliative, who will know he has made it into this privileged status prior to hospice? We had to change pharmacies this summer since the pharmacist that would fill his prescription was leaving for another job and the other pharmacist was not, quote, comfortable filling his prescription. He never doctor shopped or forged a prescription or had any criminal record or had anything in his PDPMP record, but they would not fill his prescription. His doctor's office called the pharmacy, but since this policy appendix says a pharmacist is not obligated to fill a prescription, I guess no reason has to be given. It is also not always possible to use one pharmacy because different chains have different distributor companies for various drugs. I have great concerns for people who will continue to be hurt by lack of doctor access or be cut off from doctors and or be put into an unwarranted tapered situation. What don't they understand about the word chronic, remarked a lady in chronic pain that we met a few months ago. People in the purgatory of terminally in pain but not terminal, they're out there and they will continue to be out there in our world. Chronic pain patients are not welcome in ERs. We don't go. We haven't gone for years. We weather it at home. Someday we'll make the wrong judgment. Maybe now that my husband's on palliative, we'll have a little bit of help with that. If you go, you're met with suspicion and insults and the lecture on being a drug-seeking addict. And we know people who have gone, who have chronic pain physicians and have been in that ER in pain and being lectured, and then finally they run into the room and say, oh, we found the kidney blockage on the x-ray. As far as getting a proper diagnosis, it was a 2.5-year battle to get the correct diagnosis on my husband's condition in 2001. Fortunately, his PCP prescribed for him knowing something was wrong in addition to back pain that he had. Something was wrong that medical science was not figuring out. Without that care, he would not have had, my husband would not have had the life that he had of traveling, and we had a business, and we did international travel and international sales, And then finally, when he wasn't able to do that anymore without being on pain medication, we could not have been on a plane to Boston to finally get a correct diagnosis with a pancreas specialist who could accurately diagnose idiopathic chronic pancreatitis, later confirmed to be a rare genetic mutation of cystic fibrosis. The policy says don't prescribe without a proper diagnosis. Leaving these people hanging would be wrong in our opinion. We intend to document my husband's palliative care journey. Hospice is not far away. He will not lay in bed in pain and wait to die. If there is not adequate pain control, he will have an exit strategy not related to the heading in this document. People in intractable, unremitting pain will make their decisions. Their exit strategy is death or suicide. For those of us who are fortunate enough not to have chronic pain year after year after year, remember, you are one illness, one injury, one surgery, or one genetic mutation away from long-term chronic pain. Thank you.
Thank you so much for sharing. We certainly appreciate your participation throughout this process.
I'm Scott Bainbridge, and I'm board certified in physical medicine and rehabilitation and pain medicine. I'm in private practice, Denver back pain specialist, and Mind Your Pain, a pain management focused behavioral health services provider. I'm also on the board of directors of the Colorado Pain Society, and I represent them as well as myself. I'd first like to applaud the work of the Draft Development Committee. It's a large undertaking. It's very important, and we all appreciate the work being done. Colorado Pain Society would like to use our collective experience in training in pain management to support DORA with final draft enhancement, as well as in future implementation and educational efforts. Along these lines, the Colorado Pain Society has authored a letter to DORA regarding the proposed quad board opioid policy. Stephen Wright, who you heard from earlier, has provided DORA with an in-depth and well-referenced commentary on the draft policy, which also reflects the views of the CPS. This includes our support of Colorado considering adoption of the Federation of State Medical Boards guidelines for the chronic use of opioid analgesics. This is an April 2017 update that has been vetted and adopted by over 30 states and would be an alternative to creating our own guidelines. Dr. Wright's document also includes a comprehensive list of linked provider resources that CPS feels would be a valuable addition to the current draft policy's additional resources and tools section of educational materials. I'd like to highlight two key points today, those being a precautionary note on the possibility of unintended harms that may come with the implementation of well-meaning but too broadly imposed morphine equivalent dose limits or time, such as 90-day limits on opioid prescribing for chronic pain patients, and a recommendation to improve access, including improved payer coverage for those multimodal pain management tools that we feel can be a part of the solution to the opioid crisis. The CDC guidelines, we've talked about that, were meant for primary care. They did set the bar at 50, 90, and 120 MED. When that was implemented, it had a broad impact, not only on primary care settings, but in chronic pain patient and pain management settings. So a survey was done, a recent survey of 3,108 pain patients, 43 doctors, and 235 other healthcare providers was conducted earlier this year by Pain News Network and the International Pain Foundation, asking chronic pain patients how the CDC guidelines affected their opioid prescriptions and about the consequences of many changes made. This was one of several sources used by PRR, who was commissioned by the CDC to provide feedback to them. I think it's worth me reading some of the survey results, so bear with me. The first is 84%, and these are patients, 84% say they have more pain and worse quality of life. 42% have considered suicide because their pain is poorly treated. 22% are hoarding opioids because they're not sure of future access. 20% say insurance refused to pay for a pain treatment they needed. 19% say a pharmacy refused to fill their opioid prescription. 11% have obtained opioids illegally for pain relief. 4% found better and safer treatment than opioids. 4% were given a referral for addiction treatment. 4% were discharged by a doctor for failing a drug test, and 1% found that they really didn't need their opioids. There's also an expressed concern in the pain literature and anecdotal examples on social media, in the media, etc., where people left without adequate pain management resources are turning to illicit opioids, benzodiazepines, alcohol, other drugs. Recent statistics show a leveling off of prescription opioid deaths, but a sharp rise in heroin and illicit fentanyl deaths, often in the setting of combination with benzodiazepines, alcohol, and other sedatives. Providing patients with additional pain management tools while monitoring function or gradually reducing opioid dose when appropriate provides a safer means to reach our common goals. CPS agrees with the draft guidelines' emphasis on the need for multimodal opioid management approach. We believe, however, that a collaborative, solution-based effort by providers, payers, and regulatory bodies may be the greatest chance we have to make a positive impact on the opioid crisis. I'd like to highlight a few drugs that we feel should be added to our armamentarium. Similar comments to those made earlier by our webinar guest. Tapentadol has a mixed mechanism of action and a higher margin of safety, and it is less desirable as a drug of abuse on the street. Buprenorphine, with its mu receptor agonist-antagonist properties, produces a ceiling effect, thus making it much safer. It has a higher margin of safety. Also, easy access to prescribed naloxone. That's not cost prohibitive for some people. This was a recommendation for at-risk patients by the AMA Opioid Task Force. Lastly, behavioral health services. In addition to vitally important addiction medicine roles, can also be helpful in identifying and treating comorbid conditions such as depression, anxiety, PTSD, and misuse behaviors. Specific pain medicine strategies and skills training, such as those included in cognitive behavioral therapy, can be employed to help manage pain, improve function, and reduce or eliminate opioid consumption. Offering acupuncture, massage, physical, and other manual therapies as part of an individualized patient-centered care plan can lessen the focus on opioids, but access is key, and access is dependent not only on affirmation in medical policies, but adequate reimbursement for providers. In a brief example, in Colorado workers' compensation, they have recognized the importance of behavioral health services in returning people to a higher level of function, and they have decided to pay adequately for it. Thus, access is quite easy in that realm. However, with some of our patients who are covered by commercial carriers, it is sometimes much more difficult to find access for behavioral health and other similar services. We think that improving access will be great for the citizens of Colorado, and thank you for allowing me and the CPS to voice our opinion.
Absolutely. Thank you for coming down. We'll grab someone on the webinar.
Hi, Liz. You are unmuted. Go ahead.
Yeah. Hi. Good morning. My name is Liz Alley, and I'm joining because I heard about some of these changes, and like some of the people that have spoken, I'm truly concerned. I am a 53-year-old female. I have a master's degree. I'm a tech manager for Allstate Insurance, and I continue to work full-time. I understand that there is an epidemic, but I would just suggest a little perspective. A drunk driver hit me in 1988, broke my neck, dislocated my jaw, and started the deterioration of my thoracic spine. I've had both jaws reconstructed, and in the last 5 years I've had 7 thoracic spine surgeries, including a thoracotomy. I've also had both of my hips replaced in the last 6 months and just had one revised, which is why I'm not with you today in person. I've never been drunk, believe that or not, never been high, never smoked a cigarette. I was always the person everybody couldn't wait to see if she would get drunk or high, which has still never happened. But I've been on opioids for the last 5 years off and on. It's important to remember that there are two elements to addiction, and having been raised by an alcoholic father and a truly drug addicted and an uncle, I was always really afraid of both. And what I found is that there's both a physical and a mental piece to addiction. I am blessed not to have the mental need for these medications. And when I'm not a 9, 10, 8, 9, 10 on the pain scale, I've tried after every surgery to come off of my opioids and have done so. And then only to find that there have been more problems in my thoracic spine that cause pain that goes back. I live at a 7, 8 on my pain scale every day. I know my 10. My first thoracic surgery was a fusion, a thoracic fusion. And when I asked the anesthesiologist how they were going to manage my pain, her answer was, we're not. If we can keep you at a 10 on your pain scale for only 30 days, we will consider that successful. So for about 33 days, I could hear myself screaming in my own ears, truly, but couldn't stop it. I'm also really fortunate to live with a paramedic, fireman. I live with 911, and he and my girls take really great care of me, and we made it through that. But as soon as I wasn't screaming in my own ears, I tried to take myself off of my pain medication and did. And what I found was that although mentally I knew I was done, physically I had to go through withdrawals. And I've had people say, well, why would you do that? But after withdrawal, you get your life back. And so for all of those people in the room that have been saying, if we didn't have to take these medicines, we wouldn't, agreed. I hate these medications. But what I've learned is that they allow me to have my life back. It's been determined now that I have a spinal fluid leak that is causing pain that cannot be treated for various reasons. And now I'm truly going to be chronic pain. I would suggest that 90 days doesn't suggest chronic pain at all, but a lifetime does. And that if you take away our choices, that to speak to some of the other people in the room, they're right. We will find ways to manage. While suicide has never been my choice, obviously, I get it. No judgment. I just understand it. And if you've not been in chronic pain, truly chronic pain, to the man whose legs hurt, that bone pain, there is not enough Tylenol and Advil. You might as well be taking sugar pills. So I would just say that a little perspective, kind of like having been a high school English teacher for a lot of years, I would say that you can't sweep us all with one brush. That if you tried to teach every student based on the needs of our special ed students, we would not allow the rest of our students to thrive at their own level. And I would just say that the only way for me to keep my life like it is right now, working full-time, being a functioning family member and contributor to my society, I would just really encourage that you get some perspective about what chronic pain really looks like, that 90 days is not actually chronic pain, but a lifetime is, knowing that for a lifetime you're going to be in pain and that someone may take your choices away. People will find alternatives. They will. And then you will be dealing with something other than the opioid crisis. And you will be dealing with people that have committed suicide, or that they're still finding heroin needles in their arms because they don't understand that you don't wake up from those kinds of choices. So I would just really encourage that we have amazing doctors that have given their lives in service to taking care of those of us that are struggling, and that we give them the freedom and the flexibility that they need to be able to treat those people that they know. I totally understand that Dora is trying to do the right thing, and I get it. And again, my husband's been a medic for 30 years. We lose people every day to this. I get that. But those are, I would just say that let's just give our doctors the freedom to know their people, to understand our problems. Stop letting the pharmacists and the ER people who don't know us take away our choices about what we do and where we go for our pain medication and for our relief of pain. I've been to the ER where they've literally put me in a room and accused me of drug seeking. If I go to the hospital, I'm a freaking 10. Take care of me. Try not to judge me. You don't know me. Let my doctor help me. Let my doctor judge whether we're doing the right thing. So I would just say that perspective in this case is so important, and that these opioids, while I hate them, allow me to have my life. And I can tell by the cross-section of the room that I'm not the only one. And I would just really encourage that we get a voice as you guys make decisions about what 50 milligram a day opioid usage means, and whether it's really random, as it sounds like it might be, or if we just give our doctors the ability to treat us so that we can be functional.
Thank you so much for joining us today and for sharing your story and your perspective. Okay.
Hi. My name is Elise Morgan. I'm a clinical psychologist in Boulder. I'm coming to this issue as a clinician who treats some of the people who will be most affected by the new policy, as a researcher who is trained to carefully evaluate the basis of treatment guidelines and practices, and as a friend and colleague of chronic pain patients who are literally fearing for their lives. It was in this context that I read the text of the proposed policy. As a clinician, my reaction to the policy was one of deep concern for my patients, many of whom are abuse survivors, and all of whom, by definition, could be considered to have current or previous psych conditions, which would then, by definition, put them into a high-risk group, warranting special scrutiny. For a number of reasons, I object to the recommendation of singling out these groups. First, they're a heterogeneous population, and the treatment recommendations do not take this into consideration. For example, there's mounting evidence that chronic trauma can change the way in which a person experiences pain. The threshold for experienced pain may be much higher, but once it's there, it will be at that level. So the notion that one size fits all, it makes no sense, especially for this population. And we are still exploring how the brains of individuals with various psychiatric conditions differ from one another and from healthy controls. It just doesn't make sense to issue a blanket warning about a subgroup that actually consists of numerous subgroups that differ in many important ways. In fact, the blanket application of these guidelines, as people have said, may cause more pain than it alleviates. It can further stigmatize individuals with history of trauma or psychological difficulties. It can lead to people who are untrained asking about such histories and possibly re-traumatizing these patients in a well-intentioned effort to prevent abuse, and of course by depriving them of needed medical treatment for a condition they definitely have, in the hope it will prevent them from developing a condition they are actually statistically unlikely to develop. Along these lines, I was also alarmed about the psychological effects of the pain that would not be medicated. Pain is a stressor that affects coping and quality of life. When not controlled, it decreases functioning and leads to a host of difficulties. This is obvious, and I welcome the invitation for behavioral specialists to participate in this process. However, as a behavioral health specialist, as a psychologist, it's not clear that we can handle the residual pain with a current state of knowledge. I'm very interested in alternative approaches to the treatment of pain. But first of all, the sections of the report that deal with this and that offer the recommendations actually have no references. I would be very curious to hear about the studies that they are basing these recommendations on. Second, it's great to suggest alternative treatments such as CBT. CBT does not work for everyone. It is a cognitive-based treatment that takes as its basis a number of of attributes that the patient has to bring in order for the treatment to be effective. It is not a treatment that is designed for everyone. It's for a particular group of patients for whom it can work very well, but it is not a cure-all. Also, as people have said, a lot of these alternative treatments are not covered by insurance, are not accessible to people in rural areas, and are not appropriate. I can't imagine trying to do cognitive behavioral therapy with someone who is emerging from an operation. And people have already commented on how these, quote, guidelines are actually not really guidelines in practice. And at the very least, I would urge Dora to include some strong language emphasizing their advisory nature and the need to treat individuals as individuals. Emphasizing that for most patients, the problem is not the pain medication, but the pain. As a researcher, my reaction to the proposed policy was frustration and disbelief. It seemed like almost everything I had learned in graduate school was now completely irrelevant. I'm hoping I'm wrong and that at some point somebody will present the data and the evidence on which this policy is based, but I don't see it in the report. First, one cardinal rule of research is to be sure to specify the particular group to which your conclusions apply. This is because subgroups undoubtedly exhibit relatively distinct, identifiable behavioral, psychological syndromes that lead them to respond differently to the same intervention. Yet the proposed policy applies to the same guidelines and the same threshold of 50 MME to everyone, including chronic pain patients. With this in mind, I ask the drafters the following question. On what empirical and conceptual basis did the authors combine patients who receive prescription medications with those who use street drugs? On what empirical basis was it decided that that is a homogeneous group? Especially given at the same time that the policy itself explicitly recognizes that different groups should be treated differently in its making the exception for cancer patients. Given that cancer is no longer a death sentence, we're talking about this group as chronic pain patients. It is likely that very important criteria were used to distinguish this group from the rest. Why were those criteria not applied to other chronic pain patients? Another cardinal rule of research has to do with the order in which decisions are made based on research. Implications are drawn, conclusions are drawn. The proposed policy is sweeping. It looks like it's the result of a long research project. Again, where are the analyses that justify 50 MME according to pain threshold and according to etiology? What were the outcome criteria? Where are the subgroup analyses? The research that you cite makes sense as an answer to the question, what do we do about the overdose epidemic? It does not make sense as an answer to the question of how do we medicate patients in chronic pain. Those two questions and those two answers should not be conflated. As a friend and colleague of chronic pain patients, my reaction to the proposed policy was terror. The proposed policy is an attempt to solve the problem of overdoses. But for most chronic pain patients, opioids are the solution and not the problem. It is their penicillin. I ask the board to do more research or at least share the research on which they've based this proposed policy before going to the extreme step of implementing a policy that will, in its present form, lead to withholding needed medical care from a large group of patients. Finally, I am sincerely asking for answers to these questions. and I am respectfully requesting a substantive meeting. We share the language of science. Let's use this common framework to either reach a consensus or to explain how the scientific method was used to develop this particular policy. We are the scientists and the treaters. It is our responsibility to take the hard and often ambiguous road of research rather than the recently popular road of suspicion towards some of those most powerless among us who need our help. Thank you.
Thank you so much for coming down today. Okay, we'll take one more online and then back to the audience.
All right, Shakina, we're going to come to you. Shakina, go ahead. You're unmuted.
Hi there. Thank you so very much for allowing me to speak today. I'd like to say, what so many others have said already, broad stroking never works. The unintended consequences will surely outweigh any attempt at a reasonable solution. There was a time when I was dying at the bottom of the bottom. Everyone I knew, including family, gave up on me. I was homeless, addicted to heroin, any pills I could get my hands on, and I was selling sex. To make a long story short, I embraced the fight for my life. I am grateful now to be living a stable life for over a decade, actually almost 20 years now. I now own a business, I have a family, I am thriving. I am a Suboxone patient, and I have a Colorado-issued license for marijuana. Marijuana has benefited my quality of life, as has the Suboxone. I don't struggle with addiction. I can't imagine abusing drugs, and I am so grateful for my life. Recently, I was informed by my Suboxone doctor that under the new proposed policy, he would be forced to exit me from the Suboxone program. Were I not a Suboxone patient, this wouldn't be an issue, as marijuana is fully legal in my state. My use of marijuana is minimal. It doesn't cause me to want to abuse my Suboxone or any other drug for that matter. And I take 10 milligrams daily of Suboxone. This policy is deeply flawed, and I would like to see what solid research supports forcing medical marijuana patients out of opioid treatment programs and how this will somehow benefit these patients. I don't believe they exist. I believe the continued stigma of the medical use of marijuana is what has inspired that part of the proposed policy. This policy will force me and many others out of the Suboxone program, and I ask you to reconsider doing that. Thank you so very much.
Thank you so much for your participation. Do we want to do one more online? Sure. It doesn't. There's no part of the policy that excludes anyone from medical marijuana use. Okay.
Linda, you are unmuted.
Linda, go ahead. Linda. Hello, Linda. I will come back to you, Linda. Hold on. Lisa Pearson. Go ahead, Lisa.
Hi, Lisa Pearson again. I just wanted to add to this a little bit with the story of a patient that I had that's not uncommon. I hear this weekly as people move to the state. This woman was in her late 80s, had been on the same medication for 30 years, moved to Colorado, and no family practice provider was willing to prescribe it for her. It wasn't a high dose, it was a low dose, but as these guidelines have come out, a lot of the family practice and internal medicine providers in my area have discontinued prescribing opioids at all, even tramadol. And so that can be a huge issue for people who have been using primary care for their pain and then can't get into pain management because there are such long waiting lists. For this lady, she was breaking her pills into quarter pieces to try and prevent herself from going into withdrawal. I think that I see that on a regular basis, and if you think about what that means for patients who don't end up coming to me or getting to someone else, they start going to friends and family, they start going to the streets, maybe they end up on heroin, maybe they don't, then they end up in a Suboxone clinic. If you look at like the morphine equivalent for Suboxone, 1 milligram of morphine is equal to 10 milligrams of Suboxone. Did I do that right? So it's 10 times the strength in morphine equivalent dosing as a morphine. So they end up on a higher total morphine equivalent dose with the Suboxone. And access is a huge issue. And then I would like to just reiterate what Scott Bainbridge said regarding multimodal therapy and access to care. I have a lot of patients who are insured through Colorado Medicaid, and I have many patients who, when they're in physical therapy, decrease their doses significantly, and when their physical therapy benefits end, they need to go up. I have patients that would benefit from longer-term therapy for sure, and then when you're looking at things like interventional procedures, it doesn't even pay for the equipment to do the interventional procedures for the Medicaid, and that's the only one I'm talking about at this point. So I can provide a procedure to a patient that would give them 80 or more % pain relief for a knee, and they would not need an opioid during that time, or they would need a really low dose. But Medicaid won't even cover the cost of the equipment to do it, so there's nobody else out there to do it. And so I think that if we're going to create these kinds of things, we need to create some strong language that requires insurers, not just Medicaid, but other insurers to cover these multimodal therapies so that we have options other than opioids or in combination with lower dose opioids. Because regardless of the things that we're talking about here, for some types of pain, there is nothing that relieves it as well as an opioid unless you can add some of the other stuff to it, and then sometimes that's not an option too. So we need to have everything available to us, I guess, is what I'm trying to say. Thank you.
Thank you. It's over here.
Hi, I'm Jean Martin from COPIC. We have had calls from docs. I've spoken to some who, especially now with more physicians being employed, where they are being encouraged to get rid of these patients from their practice. One actually said he had inherited a lot of patients because another provider had left town, and it was a smaller community, so he was the only person prescribing, and he was trying to taper people down, but it wasn't fast enough, and he was fired. So it's a real concern. He was concerned about patient abandonment, which is, we cover professional liability claims. And even though there's language in the policy that this does not define the standard of care, in reality, guidelines are considered some evidence of the standard of care. A physician will be asked, you're licensed in Colorado, are you required to follow medical board policies? And that's going to be pretty hard to say no to that question. I mean, obviously we try to point out that this is, you should use your judgment. And a question I guess I have, this is a lot more prescriptive policy than the one previously. There's a lot of shoulds as opposed to should consider. And so we had some concerns about that, and also the fact, I haven't heard anyone else mention it, that legislative opioid interim committee bill 2, which I don't know what Dora's position is on that or if they've been involved with it. It's called Concerning Clinical Practice Measures for Safer Opioid Prescribing. And if you look, it's on the Opioid Interim Committee website. They have 6 bills, but this one was related to prescribing. And that has a 7-day prescribing limit. There's certain exceptions, including for chronic pain. And our concern as a professional liability carrier is having multiple standards. There's going to be one standard in statute potentially, and then another standard, a more prescriptive standard, I would say, in board policies. So that's just something I just wanted to point out. Also, this is a lot compared to other policies. For example, appropriate termination of a patient. This reads a lot more like almost like a journal article with the 31 footnotes, and I'm almost concerned. We really, our risk management provides tons of education on opioid prescribing. We have toolkits and things like that. But I worry that we'll be back here, next year when some new evidence comes out, or the following year, because there were so many red lines, and I thought we had a pretty decent policy 3 years ago, and we worked on with CMS. And I would also echo other comments were from moving some really important things out of the footnotes and into the main body. One, for example, when does a policy apply? When does the policy apply? I mean, that's just in a footnote, but it's meant to apply for patients over 18 unless they're being treated for active cancer, palliative, or end-of-life care. I think that's would be important to put in the body. And there's also footnotes that have definitions. I mean, I was in clinical practice for 20 years. I'm not sure I would have known these definitions as an ER doc, like footnote 9, 23, and 25. One is the difference between a policy versus a rule. I don't think docs know the difference between that. Acute pain and subacute pain. I think I would have thought of acute pain as less than 7 days, not up to 30. Anyway, maybe that's just my ignorance. And then there was some concern on page 3, the last paragraph. This policy, it says the policy would require checking the PDMP with every prescription of an opioid. So every time an opioid is written for initially or a refill, the only exception, of, at least the way I'm reading this, maybe that wasn't intended, would be for those treated for active cancer, palliative, or end-of-life care. Unless there's really ready access to the PDMP, and I know it has gotten much, much better, I think realistically it is probably not going to be checked every single time someone comes to the ER with a, a tibial plateau fracture, or someone is having surgery and the surgeon writes, prescription, assuming how long the pain will last. If you look at Bill B, for example, or Bill 2, they keep using that term interchangeably. It's the first refill unless one of the exceptions apply. So again, that's going to be a different standard. And then we always have concerns about proper, a person can bring an informed consent claim that the physician failed to provide proper informed consent. And one thing I would recommend on page 4, the last paragraph, it requires prescribers to educate patients about all treatment options, but that may not be appropriate. I would suggest adding the word appropriate after all, like all appropriate, because you're not going to be recommending non-steroidals for someone who's got ulcers, for example. I mean, so you'd want to make sure you have that discretion there. And then just finally, the last couple of things were, some things did not seem to be relevant to the acute care setting, and I do truly understand that the board wanted this to apply for every situation, and I get that. But I wasn't sure, on page 5 there's exit strategy, and the way I'm reading this, it looks like it would apply to all patients, but are you going to need a longitudinal treatment plan? Like if someone's coming in for a kidney stone, I'm not thinking that's not something you're going to be doing in the urgent care emergency setting. And then the same thing on page 6, the middle paragraph, it seems to say that you should use risk mitigation strategies for someone being treated for more than 3 days of acute pain. So it's going to be a fair number of folks there. So a lot of those things on the risk, the way I'm reading this, and maybe that wasn't how it's intended, I don't think would apply if you're giving someone a single prescription for an acute, like an injury or something like that. So if you're writing for something for more than 3 days, the way I'm reading it, you'd have to have a patient sign a treatment agreement or prescribe concurrent naloxone. I don't think that was the intention, but it's just something I noticed in the drafting. Thanks.
Thank you, Jane. Okay, we have someone over here.
Hi, my name is Terry Schreiber. I don't often speak, but I have a long history with chronic pain. Dates back 24 years. I had my first whiplash, well, my only whiplash accident. I was in a car accident, and at that time, pain was not a fifth vital sign, and pain meds weren't even a consideration to me. I had to have 2 years, 3 times per week of physical therapy, massage therapy, chiropractic treatment in order to move my neck. And many years later, I had a second injury where I fractured my spine and tore 3 discs. And it was a whole different universe. Pain meds were plentiful. It actually took me 18 months before I went to seek medical care. I didn't know what was wrong. I knew that I was in a lot of pain and I was losing a lot of weight, but I didn't know what to do. And I got several opinions, and everyone said that I needed to take medicine. I certainly felt relief immediately. And we kept trying different procedures. and I wanted to see if I needed surgery or if I needed injections or I needed a lot of different treatments that are very common in a pain clinic. I saw a specialist. I saw a surgeon. I saw a lot of different people. The short of it is I ended up taking pain medication every day for 10 years, and I thought this was the solution. I thought it was the best option until my life was completely ruined in the way that I had expected my life to be. My doctor closed his practice suddenly for health reasons, and I took it upon myself to just stop taking the medicine. I ended up in an ambulance in the emergency room. I didn't know that I was physically dependent. I had no idea I'd created a problem. I ended up tapering off the medicine. The people in the ER said, you cannot approach tapering this way. You must continue to take the medicine. I began to taper, and within 18 months, I was completely off all pain medication. I am here today listening to all of you because somewhere along the way in the last 24 years, we have changed the way we view pain. I know there's all sorts of reasons that Porter and Jick wrote their letter to the editor. A lot of pain clinics and pain doctors believed that prescribing was the right choice, and I believe all the people who have spoken today believe they're doing the right thing, but I can tell you unequivocally that my reaction to the main pain medicine was a negative. Short term, it was great. I still can take pain medicine. There are days where I am bedridden. I cannot move. I need cervical spine surgery. I have lumbar damage. I have disease up and down my spine, and today I have taken no medicine whatsoever. I drink water. I eat anti-inflammatory foods. I meditate every day. I have massage. I have massage later today. I feel great. I feel better than I ever have. I'm running. I'm living my life. And I am an example. Maybe I'm Dr. Bainbridge's 1% from the survey that says you can get past it. But everything you said to me, you know, that I'm reviewing in your new policy, I loved. If someone had said to me day one, you can become physically dependent on this medicine and your life will be changed in some ways that are unknowable. So hyperalgesia. I had severe hyperalgesia. My pain response was so distorted that I literally thought that my pain levels between 6 and 8 on a daily basis was the best I could be. And today my pain level is usually between 1 and 3. I have pain. I live with pain. But where did we get the idea that you cannot have pain and be functioning? I think pain tells me something's wrong. Pain tells me I have a diseased spine. It tells me when I'm running too far, when I'm on my bike too long. It tells me simple little things like don't do high-impact aerobics at my age because you will hurt yourself. And so I think when you take the pain medicine, you lose the capacity to understand the transitory nature of pain. Mine's transitory. I can feel, this is a silly example, but I cut my thumb. Normally if you cut your thumb, and I thought maybe I need stitches, and I'm bleeding everywhere. I had no pain response. Now when I took the medicine, I've had other cuts to my body I'm not very good with knives, but I've had them. I've ended up in the ER, I've ended up with stitches. Today when I have it, it doesn't have the same effect. I think we're losing sight of what is happening, and I respect everyone who's trying to heal all these people. I know that I need a doctor episodically. One day I'm going to need my surgery. But until then, I am telling you, my quality of life is unimaginably great, even with my chronic pain. Thank you.
Thank you so much for sharing that story with us. Get the gentleman in the red.
Hi, my name is Michael Long. I'm a former paramedic and currently a nurse in pre-hospital critical care transport. Here representing my own opinion. And the first reading, I was kind of struck by the fact that it seems that EMS participation in this process has been missing a bit. And in the recent years, last year, 2 years, there has been some unintended omissions of EMS practice at the federal level when it comes to prescriptive authority and carrying and dispensing narcotics, and has resulted in some emergency scrambling for meetings and legislation to be enacted to correct that oversight. I did want to point out that with EMS, a large portion of the practice of EMS does involve the treatment of people who have chronic pain, who are experiencing acute pain episodes. And I've seen firsthand that many pre-hospital providers are reluctant to provide pain medications to those patients, whether out of a fear of giving a fix to a drug seeker, or whether out of a fear of starting somebody down the path of opiate dependency. And I'm a little concerned that the restriction at the physician level that this policy may represent could potentially trickle down through the development of EMS protocols and make the pre-hospital providers even more reluctant to provide adequate pain care for patients in these situations.
Thank you. We have this gentleman over here.
Hi, I'm Dr. David Bourbon. I'm a general internist in Colorado for over 30 years. I'm here representing myself. I just want to state straight away that I'm a strong advocate for opioids playing a role in patients with chronic pain. And also I have a daughter who has a chronic pain condition. And so I know firsthand the effects it can have on someone in your family and the impact it can have in that way. That said, I also worked for 10 years as the chief of internal medicine in the Permanente medical group here. And one of my roles was writing guidelines for 250 internal medicine and family medicine physicians. If you actually look at the evidence for guidelines, and I applaud the multi-board effort at writing the evidence-based guideline. If you actually look at the evidence for guidelines actually alter clinical practice very little, and which is quite a sad statement. The evidence is quite strong for that. So one of my jobs in my administrative role was writing guidelines, but I tried to take it a step further and look at how do we actually systematically implement guidelines into our clinical practice where you can actually have a substantial difference in outcomes for patients. I think our common goal here today is provide adequate pain relief for patients in a multimodal fashion, but also reduce harm and risk. The ultimate risk is risk of death for an unintentional overdose. And that's really the thing that's getting all the press nationally, and appropriately so. Being an advocate for patient care, I also have to kind of think about what are the things that the multiple boards could do to actually systematically implement some guidelines. I'm not going to go through an exhaustive list, but just to give a few examples. 40% of unintentional opioid deaths are in patients who are on long-acting opioids and benzos and sedative hypnotics, specifically methadone, fentanyl, etc. The board could actually require non-specialist physicians, i.e. non-addictive, palliative care, oncology, etc., could actually require other kinds of specialists like myself, a general internist, to have certified training in the prescribing practices for long-acting opioids, such as methadone and fentanyl. Recognizing the collaborative effort of the boards, there could be a hard stop in pharmacies that patients on a certain mill-equivalent dose of opioids could actually not be prescribed benzos and sedative hypnotics unless they actually had a collaborative consult with someone from the mental health field or the behavioral health specialty. Other speakers have spoken to the lack of pain specialists within the state and nationally. I think that's a significant problem. But you know, what could the board or the state of Colorado do? We could actually create a website with a database about who the pain specialists were, so that primary care docs and other specialists would have a better idea about who they actually could refer to. And the same actually applies to practitioners in the mental health and behavioral health fields. If I'm a primary care doc practicing anywhere in the state, who is interested in these kinds of patients, because many practitioners aren't. So what are my resources available, and how could we do that? Wearing a slightly different hat in my career, I've also served as an expert witness for the State Board of Medical Examiners reviewing cases. And I asked earlier what I could say or couldn't say. I think as long as I don't say anything related to specific patients, I'm okay. Is that accurate? So far, I'm okay. If I'm going out of bounds, stop me. But I reviewed several cases over the last 4 years related to pill mills within the state. And I was quite distressed actually working with the attorneys in the Attorney General's office when we could actually, the board could actually sanction physicians and practitioners, but could actually do very little to actually sanction the practices within the state. So the practice that I actually looked at, which was extremely destructive for I'm reluctant to call the patients, but to patients who are addicts, who actually are patients in their own right. But the kind of treatment that they were getting was completely inappropriate. But what could the boards do to work with the legislative body of the state to actually do a better job of being able to shut down what I would call pill mills that exist within the state? And yet on another note, I have a fear, and I suspect it's probably true, that because of a lot of the fears of many of the physicians to prescribe opioids for some patients and just saying no, that more and more patients with chronic pain and patients with addiction disorders are actually going to the street to get opioid medication. So what could the boards actually do to recognize that and create injection clinics or needle exchange programs within the state? What else can we do to create better addiction programs for the patients, which ultimately addresses the problem of how can we help people with pain, and how can we avoid unintentional overdoses and do a better job of serving our patients with addiction disorders as well. I'm sure there's many other things that we could do systematically that go beyond guidelines if you actually went through the guideline. And I would really like to see the boards take the next step to go beyond guidelines to implement systems of care. Thanks.
Thank you, sir. Dr. Wright?
Thank you, Steve Wright. Wanted to go ahead and at least kind of prompted me in that regard, what is the research? And I geek out on this sort of thing, but if I have missed something, please tell me, because there's nothing more than I would like to have is that the policy is commensurate with the literature, and if I'm wrong, I want to hear about it. So the assertion has been made that thresholds are useful in limiting overdose and overdose deaths. What I've found in the literature, in a widely quoted article from the state of Washington, is that they have seen a decrement in the amount of opioids prescribed. That does not equal overdose and overdose death. That's not a translation. And besides that, each one of the states, ours included, are doing 20 or 30 different things. Which one among those 20 or 30 things are actually resulting in a decrement in opioid prescribing? Now, it's important to limit our prescribing of opioids. I don't doubt that. But it's important also to look at the science behind all of that. And what is interesting to me is between 2003 and 2013, well-done study is that non-medical use of opioids has decreased by 11%. 11%. And yet, addiction has skyrocketed 3 or 4 times. So there is not a direct correlation between volume of opioids on the market and the issue of addiction. In a couple other studies, what are the what is the background of the overdoses? You know, is it because I had a bad memory and double dosed? Am I, you know, trying to treat inadequately treated pain and took too much and that sort of thing? 80% in one study, 95% in the other, and this is one research group, and this is way back in 2007, 2008, stunning that it hasn't been looked at again, had addiction characteristics before their death. So what's the low-hanging fruit in that regard? Risk management. Identify those individuals and get them off of standard opioids, no matter what the dose is. In a very large study done by Purdue, so I look at it pretty with a jaundiced eye as well, but nonetheless, 9.2 million charts reviewed nationwide. 44% of the overdose deaths had no prescription the previous month. So it's really important to understand that we can launch the ship, but that the ongoing reduction necessarily in morphine equivalent is going to fix the problem. I think it's really important to understand. And it's really important to understand on the pain management side that you know this 50 or 90 is a broad brush. There is a genetic variation of the gene that codes for the mu opioid receptor called the OPRM1 gene at the 118 position, and if you are a variant, it takes a higher dose of opioid in order to get analgesia. Therefore, you know, 50 for one person may be 120 for the other, and so it can't be applied universally. Same thing with the genetic gene, the pharmacogenetic gene of 2D6. If you don't metabolize, say, oxycodone to oxymorphone, you're not going to get the same level of analgesia. You know, so I think it's really important, and I appreciate hearing Terry and the other stories. What we really want is a policy that doesn't constrain appropriate decision making, which hits on both sides of this. You know, taking care of the pain, getting individuals that need addiction treatment rapidly and quickly off of standard opioids and into a treatment environment. And I don't see this really doing that.
Thank you. Do you have anyone online? You're unmuted, Peter. Go ahead.
He's muted on his end. Peter, you're unmuted on our end. Go ahead and go try it again, Peter. There you go.
Can you hear me now?
Yes.
Hi. I'm a physician assistant in Colorado Springs, south of Colorado Springs. Been a PA for 27 years. And I just have a couple comments. It seems like everyone's gone over most everything. But I think that education to primary care providers is important. I think it's the state of Pennsylvania has the SCOPE program that they have it mandatory that providers have to take the class so they're more up to speed on opiate prescribing. I agree with everyone that's talked about the lack of numbers for pain management specialists. We find in family practice that we'll send somebody with chronic back pain that's on opioids to pain management. They'll these patients are up to date on their MRIs, physical therapy, all of this. They'll give them an injection and send them back to primary care to prescribe the medicines. And that's getting harder and harder. We'll send people to pain management. They'll review their charts and then tell them they don't need to be seen by pain management, even though a lot of the guidelines try to tell us that if they're over 50 or 90 morphine equivalent, they should see a pain specialist, and it's close to impossible to do that. Same with mental health care. It's easier said than done to send someone to go see a counselor or a psychiatrist or even a psychologist. And I think that people that write the guidelines and try to tell us how to take care of people, we appreciate the input, but sometimes in the real world, it's very difficult to do this.
And then just another thought that people have made the comment about increasing alcohol abuse. I have a patient that has had 5 back surgeries, has wasting in the muscles of his left leg, is on chronic opioid treatment, and we've tried to bump him down, and he asked me, so the best thing I should do is get disability, become an alcoholic, and sit at home since I can't take pain medicine anymore. And I understand it's a difficult situation, but it seems like we're backing patients and providers into a corner, and I just hope that everyone understands how difficult it is for primary care to take care of these people. And in the perfect world, we'd be able to send people right out the door across the parking lot to specialists, but the real world doesn't work that way. And that's about all I have. Thank you.
Thank you for joining today.
Scott, you are unmuted.
Can you hear me?
Yes.
Hello?
We can hear you.
You can hear me? Okay. My name is Scott Hompland, and I've been listening to a lot of conversation. And I just want to give you some input from 30 years of a practice, interventional anesthesiology, pain medicine, and addiction, of which now I only do addiction. And just to give the people some ideas, it seems like the best guidelines would be those that would prevent addiction, but you really can't prevent addiction because you don't know who is going to be prone to it. To the best of our knowledge, you know, there's a number of genetic polymorphisms that would create or at least encourage somebody to become addicted to the medicines. With that said, there's a population of people you really cannot get addicted to medicines, even opiates, and there's a group of the population that you almost can't prevent them from getting addicted, and the dose that they're getting addicted to is irrelevant. So if you try to give them a small dose of an opioid, what they'll do is it'll still change the way they experience their reward pathways, and it'll still lead them down the addiction. So I think the dose of creating or not creating addiction is not relevant. From doing, can you hear me? Hello?
We can hear you.
Okay, I'm getting buzzes from multiple phones here, so I'm sorry about that.
No worry.
So I have just a bunch of items written down here. Let me just go through my checklist. The majority of the population, of course, doesn't get addicted, probably 5%. And it's difficult, as I said, to determine who's going to and who's not going to become addicted. I think the key would be to identify the addiction population quickly and get them into treatment. And you can only do that if you're very astute at managing, you know, pain and addiction and seeing these functional changes. Addiction patients tend to get more dysfunctional as the doses go up, and pain patients tend to get more functional. So it's just kind of a baseline. The third point I want to make is when it comes to people dying from medications, it seems in my experience that most of the overdoses that occur because of more than one drug being related. And there used to be this concept called the triad of death, and that was really soma or cariprazole, a benzodiazepine, and an opiate. So if you just try to limit the number of opiates that people are getting, then what they're going to usually end up doing is adding in an adjuvant medication such as alcohol or a benzodiazepine or a muscle relaxant, or even going to the street and getting some of those medications. And the problem when you don't actually treat pain patients with a legitimate dose of medicine and you have more of a pseudo-addictive behavior is, you know, patients will try to skew the whole office evaluation and ask for more medicines than they want so that they can hoard them for a trip, or, you know, do some sort of abnormal behavior which causes problems in the physician-patient relationship. Another one is the, and I'm not sure if this is still relevant, but the PDMP in the past, I would check every patient every day that was coming in for opiates, and that was just all part of the policy in my office. But there were certain facilities that did not need to put their medications down or to adhere to the PDMP guidelines, and it's my understanding who that was in the past was the VA. And I don't know whether in fact that's true or not, but it could certainly help the physicians if everybody participated in the PDMP. So it wasn't as if you could go to your VA doctor and get a bunch of opiate medicines and then come to your primary care doctor, and that primary care doctor may look at the PDMP, but those medicines that the patient received from the VA weren't listed. And I think that's pretty much it. The goal obviously should be prevent addiction and prevent the overdosage, but I'm a big fan of having Narcan around, but you have to educate the patients and especially the patient's family regarding that. So again, I don't do pain management anymore, but I did pain management for 30 years. So you're hearing the 30-year experience of somebody that did addiction and pain management. So that's pretty much all I have to say. I like, you know, somebody trying to set up some guidelines, but you know, it's going to be very, very difficult to do, and I think education is probably going to be the key. Thank you.
Thank you, Dr. Homplin. Let's go back to the audience. Who we have someone?
I probably have a different take on this. I am not one of the quadrants. They're upside down. But I was encouraged by doctors and pharmacists to speak today because I'm not a prescriber or a dispenser of opiates. And Dora's goal here is to receive input from the community so they can make correct policies. And I sometimes feel that the patient is being left behind, and maybe we should have more of a seat at the table. This puzzles me. Why, without their input, it inadvertently abandons and nullifies the patient, even though you don't intend to do that. The preamble of DORA is to help consumers, and but I'm confused here. Are we trying to protect the patient or the provider? And it's hard for you to decide what to do. You may be thinking, where am I going with this? But it's just that it would if we had patients' input, it would result in developing a more meaningful guidance to providers and dispensers and opiates. In 2000, I worked with the Department of Justice to find a solution for doctor shopping and prescription frauds, and that resulted in PDMP, and that's how patients' input can be tantamount to helping this. Without it, it's like the foxes, as my husband said, the foxes are designing a lock for the hen house without consulting the chickens. And the chickens could have some suggestions. The opiate epidemic is a complex problem. I have listened to the last stakeholders meetings, and I don't believe at that time I heard a patient speak who wasn't a provider and saying this, DORA or the community didn't reach out to patients signaling that their input was valued. And why I say that, we didn't have anything posted at pharmacies. We didn't have anything posted at prescriber's office, and even at a captured market, being the pain physician. patients had no idea the agency that was supposed to be protecting them, nor was also writing the policies that would affect them without their input or knowledge, which has been redundant because I have already said that. I would ask you consider giving us a voice. And then secondly, when CDC released these guidelines, it was predicted that policies and payers were quickly moved to convert CDC's voluntary recommendations into mandatory regulations. And to address this opiate epidemic, CMC has implemented a medication safety approach by which sponsors are expected to reduce beneficiary overutilization of opiates and maintain access to needed medication. The agency has said in a statement that it wanted to better align its policies with CDC guidelines. CMC is proposing a daily ceiling on prescribed opiates at 90 MMEs, and any dosage above that would be considered excessive. The Centers for Disease and Medicaid Services, CMC, has announced plans to fully implement the opiate prescription guidelines released by the CDC, which recommended doctors not prescribe opiate medication for chronic non-cancer pain. That's what is in their guidelines. What makes this pain different from other pain is a question that many of us ask. CMC has taken the CDC one step further, however, by mandating them as official Medicare policy and taking punitive action against doctors and patients who don't follow them. The CMC's quote-unquote Big Brother approach to fighting opiate abuse by developing a strategy that would encourage pharmacists to report doctors who may be overprescribing opiates and patients who may be abusing them. Information about these potential opiate overutilizers would be shared with insurance companies. Insurance companies would be empowered to prevent opiate overuse at the point of sale at the pharmacy. CMC contracts with a dozen of private insurance companies known as sponsors to provide health insurance to about 54 million Americans through Medicare and 70 million through Medicaid. Insurers would be expected to police pharmacies, and doctors and patients who do not follow these CMC guidelines are CMC is potentially dropping them from Medicare coverage and their insurance networks. Such policy change would have a sweeping impact across the U.S. healthcare system because so many insurance and patients are involved. CMC mandates would cause previously stable payments to suffer acute withdrawal with or without medical complications. The reiteration for DORA or CD is that policies are not rules but guidelines. But they already are playing out to be rules. History has shown that government guidelines become laws. And the insurance companies are using these rules to avoid paying for opiates. The CMC and VA are mandating the adherence to the CDC guidelines and dropping providers from Medicare coverage and their insurance networks. CMC is not the only agency that is tightening the screws on the high-dose prescribers. Under the new guidelines, that are considered by the National Committee for Quality Insurance, healthcare providers who provide patients more than 120 MME equivalents over a 3-month period would have points taken off from their quality scores. Patients now share a concurrent responsibility with prescribers of opiate drugs. Insurance companies will police them. Insurance companies will penalize them in the same way they are affecting prescribers. Insurance companies would simply drop them and penalize their revenues by dropping the pharmacist company's coverage under the insurance companies. How are we supposed to believe guidelines will not become law? Mandating by insurance plans requiring dosage not to exceed an arbitrary equivalent, and it is already happening. Sorry, I'm missing a page. The opiate epidemic solution by setting MME has had detrimental effects. Many providers and pain specialists have requested MME be removed on page 6. I concur with this as I have explicitly shown examples when MME had unintentional devastating effects. The MME guidelines were manipulated by the insurance industry, the Veterans Administration, and the CMS to reduce costs or increase the revenue on their income statements. More alarming, doctors are being told how to treat their patients, and pharmacists are being put in the middle of this mess. Prescriptions for opiates have declined since 2012, but opiate-related deaths are increasing due to fentanyl and heroin use are skyrocketing. Most of the public believes that fentanyl is being prescribed, not illicitly manufactured by Mexico and China. Just recently, HLN, a television network, had one piece educating a small population that fentanyl on the street came from China and Mexico instead of diversion from prescription drugs. The general public doesn't even know what tolerance means, the difference between mental addiction and physical dependence, let alone the CD guidelines, where let alone the CD guidelines were influenced by PROP, a lobby group against opiates to treat chronic pain. The lack of information about opiate use creates severe judgment and criticism for those who have a prescription. What caused the epidemic and sustained it today are just not the same. And this is a quote from Stephen Crescent, the University of Alabama internist and addiction specialist. Wrapping this up, we need to drive an opiate policy that doesn't lead to another epidemic and is substituted for a suicide or heroin problem. I is encouraged to speak specifically to the patient abandonment issue, but if I would initially use this term, immediately most of the people would have gone, oh no, and it causes people to bristle and think differently. However, my goal was in this piece was to show how patient abandonment can take it in different forms. And unfortunately, patient abandonment is already happening as these policies are already morphing into law.
Thank you so much. We really appreciate your perspective as a patient.
Sam Myron again. After listening to all this, I would really encourage people to look at why we were doing this. Is this just a panacea to say we did something? Or is this based on science, or is it just based on emotion?
Young lady in the front.
Hi, my name is Alicia Andrews. I'm representing Peer Assistance Services, and I'll be brief. We had a few recommendations for Appendix 2 regarding drug testing and the specificity of that, and as well as the SBIRT in Appendix 4, which we can talk more offline about. But I just wanted to let you know that we do have some recommendations that we'll send over.
Thank you, and we appreciate you coming. Do we, okay? Do we online?
Andrea, you are unmuted. Andrea?
Go ahead, Andrea.
Can you hear me?
Yes.
Can you hear me now? Okay, sorry, I apologize. Hi, I'm representative of the Alliance of Treatment for Intractable Pain, a peer group with physicians, scientists, researchers, journalists, and patients. I would just like to address two things very briefly. The first is the issue of morphine equivalence. In a recent study posted in Medscape by Dr. Fuden, Farm B, and Michael Chapman, they raised the issue that morphine equivalence formulas really are not consistent across any discipline, and the use of a morphine equivalence can result in a broad range of doses. And he questions in his study the veracity of even using morphine equivalents to create public policy. And I would encourage you both all to think about whether or not even the standard of morphine equivalence is reliable enough to be constituted as public policy. The second statement I'd like to make is just that Colorado State seems to be going even further than the CDC guidelines went. CDC guidelines recommended 50 as an average dose, but up to 90 without requiring any additional concerns. And I'm curious as to why the board in Colorado is drawing such a bright line at 50 milligrams when nobody else has gone as far as this goes. Lastly, to state that 90 days is sufficient for the treatment of chronic pain, to me, just shows an absence of understanding of what chronic pain actually is. Over 200 diseases have pain as one of its symptoms, and many of those have no hope for cure. Many people in these conditions use opioids only to survive, to be functional, to raise their families and participate in community and work activities. And an arbitrary limit of 90 days could result in grave harm to this entire patient population. And we urge you to reconsider those guidelines in light of these facts. Thank you.
Thank you. Okay, let's make, before we start on second round here, let's make sure everybody else has had a first chance because we're getting toward the end. Okay, go ahead.
Very brief, just to add to the MME difficulties, there are certain medications where it is not easy to make the conversion. Tramadol, tapentadol, buprenorphine stand out, and if we are going to stick with the MME limits, that we make exemptions for those.
Thank you. Dr. Wright?
And to amplify that further, the piece in the work that Jeff Fuden does is really quite important. If you look at the conversion tables, there is a 300% difference in morphine equivalent dosing with respect to methadone. That really needs to be set out as a separate category altogether. If you use the Washington State Agency for Medical Directors conversion from methadone to a non-methadone opioid, there's a very high risk of overdose in relation to that. A lot of providers confuse the use of these calculators as tools for rotation, and indeed that should not be the case. How are these developed? These were the equivalents were identified by taking healthy volunteers and seeing what happens. Individuals that don't have co-occurring diseases or co-medications. When you look at buprenorphine and tapentadol specifically, a lot of these conversion tables, they're based on efficacy. how well it helps pain rather than overdose potential. And when you do the conversion for, say, buprenorphine, it gets a relatively high level of morphine equivalent, and typically that is derived out of how well does it treat addiction. It does, however, have a ceiling on respiratory suppression, and the same is true for tapentadol. It is not about the analgesic efficacy similarities because it has a dual mechanism. The real issue is respiratory depression in relation to overdose and the risk there. This really isn't addressed in the morphine equivalent, and I would agree with Scott that what really needs to happen is to pull buprenorphine and tapentadol off of the calculated list because they are uniquely different, relatively significantly more safe, and don't pose the same kind of risk if it's going to be used at all. Probably the very best of very poor calculators is the one from Practical Pain Management. And you can go into the literature and kind of sort this out yourself in that regard. But we want the best of the best if we have it, there at all. I'll stop there.
Okay. Thank you, Dr. Wright. We have one more person online here.
Danny Benton, go ahead. You're unmuted. Danny Benton, you're unmuted on our end. Go ahead.
Hi, sorry about that. Okay, yeah, I'm a little late to the conference because of networking issues, but I just wanted to talk about the information that's being circulated out there as a pain patient and what I've been able to gather from CDC statistics and other information that is floating around in the mainstream media. What they don't seem to be covering is polysubstance abuse when it comes to overdoses, overdose case. They're also not covering suicide, potential suicides. We've seen suicide rates skyrocket since doctors, specifically primary care physicians, have started to detox their patients, usually unwillingly. Those statistics, I mean, they're not hard to find, the suicide rates, if you just go out there and do a search for them. That was one thing that I wanted to talk about. Let's see, there was another. Yeah, another drug on the conversion table that is another tough one to do conversion is fentanyl, like a fentanyl transdermal. I know that from personal experience that a conversion from the fentanyl transdermal 25 micrograms to morphine was, to methadone was an extremely rough transition. And so yeah, I think those type of things need to be tightened up. And lastly, I don't think that that it's clear to people the difference, or being made clear to the general public that there is a difference between addiction and dependency. And people who have been on pain medication, opioid based treatment therapy, and for much of their life, like me, and could not work and could not function, could not have a family without it. We are we're being lumped into a category of people who abuse these drugs for totally different reason. And you see things like CVS has recently started basically a filing system, and they're refusing to fill more than a 7-day supply. And I believe that these measures that they're taking are really going to create another epidemic. Already brought up the suicide epidemic. Also, I spoke to a friend of mine recently who works at a harm reduction clinic, and he told me that the uptake, he's a coordinator for the clinic, and he told me that the uptake for, they're seeing a lot of patients who are unable to transition to pain management from their primary care physicians. Either there were no spots available, or the pain management doctors were either at capacity or were unwilling to take them on. And they're seeing more people end up using black market drugs. We know that a year or so ago, that maybe a little longer, that heroin started showing up in the black market supply of heroin, which caused a lot of overdoses. And what my friend said to me was surprising, that it seems that to counteract the effects of the fentanyl, which is a sedative type effect, whereas that wasn't what was occurring for the people who were using pain medications or opiates. To balance out or counteract those side effects, there's more people that they're seeing that are either using not just heroin, but they're also seeing an uptick in cocaine and methamphetamine use, and sometimes in a combination of the three, which gets back to polysubstance abuse. Not to mention that, in a lot of these cases, you also see benzodiazepine use for the anxiety that comes with using these medications sometimes. But with like I said, the suicide rates, the uptick in other drugs that are being used to counteract negative side effects from things that are in the black market supply, we're really creating some problems here that if they're not addressed soon, I think that we're going to be a lot worse off in the end. I can see this for our government as kind of low-hanging fruit. They've wanted to win this war on drugs that we've been fighting, well, let's say for 40-plus years since President Nixon declared it, even though it's actually been going on for hundreds of years, but I'll go with 103. I could see how they would think that this would be, this could be a simple win for them. Unfortunately, they're going after the wrong people. So many veterans are suffering, so many chronic pain patients, so many intractable pain patients, so many even patients who are suffering from cancer are unable to get their medications. And I've talked with so many physicians on the phone, through social media, and my own physicians who are just flat out not willing to take the risk because they see one or two doctors, get prosecuted in the area, and they lose everything. They do jail time, or they lose their license, and it affects their livelihood. And many of these doctors that I've talked to are still paying back student loans, and these aren't young doctors. These are people who've been physicians for 20, 30 years, and they're getting out. They're bailing out, and this new generation of physicians has, they've been taught, to treat pain in a different way. And as a person who was prescribed opiates after after a horrible car accident when I was 18 years old, and I went through everything, the physical therapy, the different types of nerve blocks, epidurals, radio frequency. That's just for my back issue. I have tons of, a ton of different types of issues, neurological issues as well. But it's I kind of lost track there. But it's really upsetting to see how I'm being treated now versus the way that I was being treated then. Doctors just are not willing, and I had a doctor tell me, he's just like, I'm not willing to take a risk for your quality, you know, when I brought up my quality of life, you know, I'm just not willing to do it. And my physician even outright lied to me, told me that there was new legislation in my state, and him prescribing me a taper dose from methadone was illegal. And when I asked him to link me to that article, he could not. And I follow state law very close here, and there was no such law. So anyway, I'm going to wrap it up there.
Yeah, we're already 15 minutes over, so if you could just wrap up your comments.
Yep. Yeah. Thank you all for listening. I hope that you'll give this some serious consideration from the patient side. Yeah, doctors definitely should have been using the PDMP more so than they were a long time ago. So I'll leave it at that. Thank you all, and thanks for hosting this conference.
Thank you so much for sharing your story and your perspective. We're always appreciative to hear the patient side and potential collateral consequences of the policy. Okay, Terry?
Hi, Terry Boucher with Colorado Medical Society. I kind of have a question as opposed to a statement. Marjorie and I both serve on the Prescription Drug Monitoring Program State Committee. And when we started working on the PDMP, one of the questions that came up was, do we want to track MMEs? And what we discovered at the state level was there were so many formulas that no one could agree on that if you look, PDMP does not track MMEs. So my question to Dora is, who is going to track the 50 MME per day, and what formula will you use? And I think that if you're going to do that, you need to make that decision and put it in the guidelines.
And I think, as we've stated, this is policy. We're not regulating by it, and we're not tracking, we're not following people. We're making recommendations, a bright line. If you're at this amount, stop, reweigh the risk, put any mitigation strategies in effect that you need to. There's nothing in this policy that says you can't go over 50. It says if you're going to, step back, take another look, make sure it's in the patient's best interest, and then make sure the patient is safe. And I think that, to me, is sort of the hallmark of the bright lines. There's no limit at 90 days. There's no limit at 3 to 7 days. Instead, it is, if you're going over this, make sure the patient is safe. And that's really what we're trying to do here. Ma'am? And then we're going to have to get this wrapped up here, so.
So this is the second stakeholders meeting I've been at, and there's been, to the extent there's been a consensus, and there has been a consensus, there's been a lot of objections made to this policy. And I know Dora has based this policy on its own group of experts, on its own doctors, its own mental health professionals, and perhaps its own consumer advocates. It looks...
Let me stop you there.
Yeah.
Because I want to remind you that for the previous 18 months, we held 5 stakeholder meetings across the state, including webinars in which we took comments from all constituents, and that also formed these guidelines. So I just want to make sure that that's included as well.
Right. So it seems clear that the 2 that I've gone to is drawing on a different group, because most of the people have objected to it. And, you know, we're used to having different opinions. Research is not something that gives us a unitary answer usually. I'm asking, is there some way to get whatever this target group is that's been drawn by the last 2 stakeholders meetings included in the next discussions? Because obviously there are really a lot of very impressive experts and consumer advocates here.
Thank you. Okay, anybody else? What I can tell you is that once we meet with the board member work group, we will hold another stakeholder meeting where you're all welcome to attend.
And will we be able to speak to the drafters of the policy?
The board work group, you're welcome to attend that meeting, and there'll be a comment period at the end. Mm-hmm. Who is it? Okay. Go ahead, Sally.
Hi, hopefully, can you hear me okay?
Yes.
Okay. You know, I think that there's been a lot of talk with regard to the way that physicians and also pharmacies are interpreting some of the new guidelines that are being set forth, starting with the CDC guidelines. And regardless of the fact that it's been stated that these will not be enacted as law, that's the way that doctors and pharmacies are viewing them. So, you know, I'm reiterating what some people have said, but physicians who have had patients for years who have been productive members of society while on opioids are now not prescribing those to their patients any longer. We have the CVS issue where they are not filling prescriptions for more than 7 days. So my question to you is, how can you communicate effectively to physicians and also to pharmacies that they have to respect the doctor-patient relationship and what the doctor's recommendation is for that individual person without fear of some type of retribution?
And so obviously outreach and education will be a big part of rolling out the revised policy. Also keeping in mind that the policy as it is has been in place since 2014. With these recommendations, there's obviously some changes, some dropping of the bright lines, but that the policy has been in force now for over 3 years. And when we roll this new revision out, we will definitely embark on some education and outreach.
So I would make a recommendation to the board that you have consistent communication with physicians with regard to how this is affecting the way in which they see their patients, and to ensure that physicians aren't feeling as if these new guidelines are in fact law.
Okay, thank you. Anybody else? Are we good to go? Okay. Thank you all for coming. Appreciate your time and your comments. Your feedback is appreciated as we take this back to the board members. The board member work group will look at the suggested revisions by the stakeholders, and then we'll make any necessary revisions, and then we will post another stakeholder meeting. Great. Make sure to get hold of you again.